everyone. Thank you for being here. I'll just give people one more minute to join and then I will start us off.
Wonderful.
Okay. Continue admitting. Okay. I'm sure we'll have some more people trickle in, but I'll get us started. Thank you all for joining us today. APA Division 40's Association of Neuropsychology Students and Trainees, ANST, is excited to host this webinar as a part of our ongoing commitment to supporting trainee development in clinical neuropsychology. My name is Destiny Weaver, and I am the networking officer for ANST. I'm in my third year of my PhD program at Wayne State University. We'll be joined shortly by the moderator of this session, Dr. Sandra Morales. Dr. Sandra Morales is the Professional Development Officer for ANST and a first-year postdoctoral fellow at the Barrow Neurological Institute. Today's session is designed to introduce you to the foundational concepts of fact-finding and neuropsychological assessment, an essential skill for developing accurate case conceptualizations, guiding test selection, and improving clinical decision-making. We're glad you're all here and we look forward to an engaging and informative session. With us here today, we have Dr. Joel E. Kamper to tell you a bit about Dr. Kamper. Dr. Kamper is a board-certified clinical neuropsychologist and the training director for the Neuropsychology Postdoctoral Fellowship Program at the Tampa VA. Dr. Kamper also has a passion for teaching and training and serves on the boards of several neuropsychological and training organizations. This interest extends to helping students and candidates prepare for board exams, and he retains a curious affinity for doing fact findings. Other professional roles include longstanding involvement in licensure and EPPP development through the Association of State and Provincial Psychology Boards. While working in a rat lab in graduate school, Dr. Kamper was also in a cover band with his lab mates, and he played on the lucrative scientific conferences circuit. He continues to enjoy playing music as well as competitive sailing. You are all more than welcome to submit questions throughout the webinar to Dr. Morales or myself directly. While we will do our best to address as many questions as possible, we may not be able to answer all questions due to time constraints, but we can take note of them to see if they may be answered at the next session. And yeah, thank you all again for joining. And with that, I will hand it over to Dr. Kamper.
Thank you so much for that lovely introduction, and nice to see everyone. Let me share my screen here. Okay. Can you all see my screen? Good. Thank you very much. All right, and appreciate that kind introduction. Joel's fine. Hi, nice to see everyone. Happy Friday. So I'm here to talk to you all about fact findings. We're going to go through kind of some basics here today. The ANT staff were lovely enough to give me a series of questions in advance that you all have submitted. So I have those handy, and I left plenty of time to kind of address those things and any other questions that come up at the end, because this topic is much better as a sort of a dynamic thing than it is me just talking, of course. So this is part one. Next week is part two, when we're doing a live demonstration. I will have someone helping me. Probably myself will be in the hot seat because no one wants to volunteer to do that, but I, as was shared, have a strange affinity for doing these things, and I don't mind. So with that, I will get started. So this is me. I have nothing to declare. I can't obviously prove or attest that the U.S. government shares my views on how to conduct clinical fact findings, but there it is. So I am a professional fact finder. Okay. So here are our objectives for today. So we're going to talk about the purpose and structure of the fact-finding process. We're going to talk about how to gather and discuss case information in an organized way, demonstrate how to talk about clinical decisions, which is always a tricky thing for a lot of folks. And then I have an orange because it's not really an objective, but it is, I think, the most important piece of this, which is answering questions and kind of integrating this into what you all do. So with that, we're going to get started with an immediate tangent. I'm very prone to getting distracted, as my residents will tell you. So we're immediately embarking on a detour here. And I want to talk to you really briefly about just kind of the board process in general, because I think this is kind of a helpful background. We won't spend a lot of time on this, but just to kind of give an overview. So there's two, getting boarded is sort of a quasi-soft requirement now for most people that are graduating to do eventually, not right away. There's been a major uptick in the number of folks who are boarded, and I know ANST, Division 40, and ABCN have all been, and AACN actually have all been trying to recruit more folks to do it, including those from different diverse backgrounds, which has been really cool. Doug Whiteside and I gave a talk for Relevance 2050 last year to that. We're trying to get more folks to kind of go through this process because it's helpful for you for career, and it's helpful for the public just to know kind of that you have a level of competence that you know what you're doing, which is always a good thing. So there's two main certifying boards, ABAP, which is the one we're going to talk about today, and ABN, which is the American Board of Professional Neuropsychology. Their process is very similar to the ABAP process, but so a lot of the things we'll discuss are probably portable for anyone who does go through their board. But most folks go through ABAP, which is the board that's been around the longest, and I think is much larger as well. So just to kind of briefly talk about how you would get to be board certified. First, you have to graduate, obviously. There is an early entry option with ABAP that hopefully most of you are familiar with. I think you can actually submit at any time before you're licensed, I want to say, is kind of the cutoff. When I went through, I had to mail things in. It wasn't that long ago, but feels like it. But now I know it's all online, so you can actually bank your credentials online, which is nice. So you save $100 if you do it early. It's $25 to submit your application, and you can start banking your credentials whenever. After you're licensed and you've completed your postdoctoral training, either through a formal or even an informal program, you have to upload those completion certificates, and then that finalizes your application and you can submit it. And that kind of gets you started. And then you have 7 years, although I heard just actually, I think earlier this week, there's going to be an amendment to that for folks who are pregnant or have other life circumstances that get in the way that mean that they can't kind of go as linearly through the process as they would like, which is, I think, a wonderful change. So these are sort of the four main pillars of getting boarded. So the first thing is a credential review. This happens kind of behind the scenes with your application. If you've completed a formal postdoc program, a formal 2-year program, that is either APA accredited or an ABSIN member, you can check a box that bypasses a lot of the detailed part. If not, that's no problem, but you have to submit sometimes syllabi or other evidence that you received training in brain behavior relationships, basic assessment, competencies, and a host of other things that you can find on the ABCN website. Once approved for that, you can sit for your written exam, which is, I think it's 100 questions. It's become a bit more practice focused, and they've integrated more rehab content, which I think is great. It's a bit sort of more appealing to more folks now. So that gets completed at a testing center, just like any other standardized test. Once you pass that, you get invited to submit practice samples, which are cases that you have seen yourself. They can't be cases that you supervised, but they can be technician tested. So you submit 2 practice samples that are kind of a good summary of the work you do. And then if those are approved, which they usually are, then you move on to sitting for your oral exam, which is the part that everyone is worried about. Okay, I'm going kind of fast through this background because I want to leave plenty of time to talk about the actual fact-finding stuff. But any questions so far on and kind of this crash course? Wonderful. Okay. And Destiny, you're collecting any questions that come in, but if folks have any burning questions, you can put them in the chat or interrupt me. That's fine too. That's not a problem. So the oral examination is a 3-hour exam. There's 3 components. Something to remember is that you don't pass or fail individual portions. You pass or fail the whole thing. So there's a myth, I had heard it, when I was going through that, as long as you pass 2 of the 3 components, then you'll pass the whole thing. And it doesn't really work that way. You could do, okay on all of them and not feel great and still pass, or have, some unusual insight or flash of brilliance during one of the parts that kind of really shows what you're doing, and not do so hot on the others, and that could be okay too. So there's a panel. You and a couple other people will basically have the same examiners, and you rotate through when you go. And after, it's usually like a Friday and Saturday, so there's 4 sessions with the same number of panelists. After that's done, the panels meet and talk about the folks on their slate, how they did. And then I don't know exactly what happens, but you find out about a week later whether you passed or not. And if not, then you resubmit new practice samples and kind of go again. It's not uncommon for folks to have to go through orals again. It can be a pretty nerve-wracking experience, but I'm here to hopefully make it a little less scary and intimidating. Okay, so the case defense is the first part, and that's where you basically discuss your practice samples. You're going to get asked questions about why you diagnosed what you did, alternative questions or hypotheses you may have had. Anything that is kind of in there or you discuss as a rule out is fair game for follow-up questions. So one of my case samples was a fairly straightforward Alzheimer's disease case, but I mentioned some sleep problems, and so my examiner asked me about other diagnoses, and I mentioned there was a tremor, and she said, that sounds like Lewy body. Why did you not diagnose that? So I talked about, why it was AD instead, and she said, what are the core criteria of Lewy body? Like, list them off. So that's fair game, and that would open up, having to discuss that or anything related. So you want to kind of learn things that are around your case. It's helpful then to pick cases that are relatively straightforward. Don't try to impress them with some complex, rare thing because it's going to be controversial. The most boring, straightforward case that you see, on a typical basis. So mine was an AD case that was relatively clean in someone with a right hemisphere stroke. It's pretty straightforward. So that's first part. The second part is your ethics exam, where you're given an ethical vignette that is chock full of ethical pitfalls and problems, and you have to identify them. This part for most folks, including myself, was kind of the easiest or the least nerve-wracking. They will ask you what you might do differently. For those, as I'm sure many of you who are still in graduate school, this may seem a little overwhelming, or how will I know that? It's really interesting what a couple of years of practice independently will get you as far as knowing some of these ethical things, and you build confidence just kind of naturally as you go. And then, you study a bit before you actually go for boards, but it's a little bit less of a heavy lift than it may seem by the time you get there, which is nice. Part of that is also what's called a professional development interview, where they ask you things like, how do you stay current? What is a current issue in the field and what's your opinion on it? Why do you want to get boarded? things like that. And that's also where they ask if you have your own ethical dilemma you've encountered, and if so, what that might be. And then after all that, we get to the fact finding, which is here. Okay. So now we're going to end our detour and get back on track. Okay. So what is a fact finding? Well, a fact finding is an open-ended clinical vignette, but it requires you, I said examiner, I meant examinee, apologies. It requires the examinee to actively elicit relevant data. So you are given a prompt, you're referred a 36-year-old male, who's complaining of memory problems, and then you have to kind of go from there and ask questions that are going to get all the data points that you're going to need to kind of make a conceptualization, which seems kind of hard. I think this is the most nerve-wracking part of the oral exam, and because the oral exam is the most nerve-wracking part of going through the boards process, this is the thing that everyone is kind of afraid of and seems kind of mysterious. I'm hoping by the end of next week, after we've gone through this content today and then done the live fact-finding model, it'll be a little bit less scary, because, well, here's kind of the things that it requires. So communication, knowing your functional neuroanatomy, knowing your, being able to interpret data and reason through things, and then conceptualize cases, which really is just what you do every day. So the kind of cool thing about fact findings is it's just what you do every day as part of clinical practice. And for those who are, in graduate school and in practicum programs, it's that clinical practice is something that you get much more fluent with as you go through your training, of course. I tell people this, it's what you do every day to try to make it seem less scary. The rebuttal is always, well, if I don't do well, what does that say about me as a clinician? But it's externalizing it. It's talking about things out loud and under time pressure. That's what makes it hard, and the anxiety of going through it. So I'll have some tips and kind of demystification sort of details here in a minute that should help with that. It's 45 to 50 minutes. The three modules are like an hour each, but you have to, it's in Dallas and Chicago now, I think, depending on the time of year. But you have to walk from the little holding pen where they have you to the exam room for each portion, which takes a few minutes. So figure 45 to 50 minutes. And one thing I really want to highlight here, the goal for doing fact finding is to demonstrate that you have a working knowledge of brain behavior relationships, of what we do, what our field is all about. Getting the right answer, figuring out what the diagnosis was and getting it right, that's nice, but it's not required. My actual fact finding, I was very close to the correct diagnosis, but didn't have quite all the details right. But it doesn't matter. It's about the brain behavior relationships, and kind of getting in the ballpark. Okay, so here's some steps to doing a successful fact finding. So the first thing you're going to do, and we'll demonstrate this all next week, and I can, Destiny, I can send these slides out to you, as well as some templates that we're going to go through here in a bit, so that you can feel free to distribute, so the folks can follow along next week. But the first thing you're going to do is write out your template or rubric. I'll have some examples of that in a minute. That's going to take a couple minutes. Not everyone does this. I personally think it's a good idea to at least have a couple points that you're writing down at the very least, because even if you feel really comfortable, it's easy to get kind of caught up in things and forget. So my actual fact finding, my patient had been referred from a neurologist, and I forgot to ask what findings the neurologist had from their exam, when the patient came to see me. My examiner was very gracious and said, "There's something you missed. Would that be helpful to ask about?" And I said, "Oh, yes, it would," which was very nice, but they may or may not do that. So writing things out kind of helps you organize your thoughts. I will also add, I'm going to share a couple models in a bit, but everyone kind of approaches this a little bit differently, so use what works for you, with practice, of course. Okay, the second thing you're going to do is collect your background data, or the history. maybe 15 or 20 minutes. So this is the point from that prompt all the way to getting through your initial set of differential diagnoses, where you're going to ask questions to get all of the data from the patient's history that you need. I'll have some rubrics for that here in a slide or two. And then you also want to provide some initial differential diagnoses as sort of a nice little break in the process where, here's some initial thoughts I have based on what's going on. And by that point, I usually tell folks to aim to be about 20 to 25 minutes in or so. I know these numbers don't add up to that, but if you're, on the lighter side with your rubric and providing the initial differentials doesn't take too long, yeah, about 25 minutes or so is about right. You then move into gathering and reviewing test data, including behavioral observations, which takes about 10 minutes. Doing the conceptualization and summarizing the findings, which is, I think, the point of the fact finding that everyone is the most worried about. There's another 10 minutes, recommendations, and again, those numbers don't quite all add up, but give or take a minute or two with some, that should get you to about 45 or 50 minutes. Okay, so I mentioned a minute ago that the fact finding is what you do every day, and to kind of use your own practice as a guide. Now, I know for a lot of us, if you're in training, you may not have sort of your own preferred template or practice model yet, and that's totally okay. This is just a thought to kind of put in your back pocket for the day when you will, and to kind of use that as a guide when you're preparing to, for boards down the road. But I'll offer this. This is sort of my organization for my reports. This is what I would use. The order and titles of these may vary depending on what you or your supervisors tend to use, wherever you guys are training. But these are my headings, and the template that I use when I write reports has these headings, and I do this every time, close to it. Which means I kind of have this table memorized, which means if, when you go for a real fact finding or even the practice ones, you can take 30 seconds and just kind of sketch out the background demographics, background history, patient complaints, all that on a piece of paper, and then check them off or whatever you're going to do as you go down to make sure you don't miss anything. So you'll see here, I try to have this flow from getting referral information, and don't forget to get notes from the referring provider, like I did. Demographics, any background information if it's available or applicable. It may or may not be. If someone has a, just kind of slow, insidious, or lifelong, syndrome, there may not be a background. But if there was some event that happened, then there might be. Keep in mind they're not going to tell you everything probably, because that would give away, whatever the answer is. If you have a patient, let's say, that had a TBI that required some sort of surgery, decompression surgery, they may say he had neurosurgery after an incident and was in the hospital for a few weeks, but they're not going to tell you the details because that would kind of give it away. And that's okay, but just kind of be prepared for that. Patient complaints, including the course, which is very important, symptom onset and progression, or lack thereof. Is this something that came on abruptly, or is this something that developed over time? Has it gotten better over time, or worse, or stayed about the same? Any collateral complaints, family members or friends who came with them? How are they doing day to day? History of prior testing, imaging labs, other clinical data points. And again, if this is the breadth of this information are things that you're not comfortable or familiar with in your training settings or practice, that's okay. You'll get there. But these are kind of the things you want to be thinking about. Medical history, med list, substance use history, family history, and then social history kind of being last, at least for me. Okay. So there's a few ways to think about differential diagnoses. When I was initially practicing for doing fact findings, when I was in residency. And by the way, getting good at doing fact finding is definitely a skill that takes practice. I completely bombed my first fact finding. Um, Most people don't, knock it out of the park their first one because it's a skill. It takes time and kind of work to be able to talk out loud. But it's really helpful to have a set of some sort of mnemonic for your differentials. So what happens when you get in the process is you're kind of thinking through the patient's symptoms, you're writing things down on your paper, maybe plugging those into your rubric, and things are going to be bouncing around your head of what might be going on. And it's very easy, especially if you haven't done a lot of these, to get sort of fixated or focused on something that kind of seems obvious. Oh, this sounds like Alzheimer's disease or whatever. And then have that thing kind of be stuck in your mind, and it kind of makes it hard to think about other possible diagnoses. So my first practice case, when I was a resident, was posterior cortical atrophy, which for those who are not familiar with that, it's a form of Alzheimer's that starts a little bit more posteriorly in the parietal lobes, and that visual spatial dysfunction is as a primary finding. I didn't get it. I landed on vascular dementia. And there was only tenuous evidence for vascular dementia, but gosh darn it, I shoehorned every bit of data into that vascular dementia diagnosis because that's the only thing I could kind of think of at the time, because I got nervous. So using a rubric is very helpful. I would write out your rubric for diagnosis. I wouldn't think you necessarily need to go through all of them because it'll take time. I tried during my real thing and I was told, no, just give me a couple. But this is one I really like, and one that I tell folks that I would recommend using. So this is the vitamins. There's different versions. This is the vitamins ABCDE version. I picked this up from our colleagues in neurology. Their residents do this when they're talking through cases. And this, as I'm sure you've been kind of seeing on the slide, hits a lot of the major etiologies that we may be worried about, when we're thinking about a case. So the acronym makes it a little bit easy to remember. The version I had psych as an S because of the sound, and that's just confusing. So with the ABCDE, we've kind of given it its own little home. We're going to run through a very, very, very brief case example here on the next slide, where I'm going to show you kind of how you might use this differential to help yourself when you're doing fact findings or just in your clinical practice even. So I've made up this case. This is a 63-year-old male, history of abrupt onset cognitive changes, which have worsened over the last year since they started. History of diabetes, sleep apnea, went on a safari in Africa 14 months ago. So it's about 2 months before symptom onset. Family history of Alzheimer's disease, and seen as an outpatient. Okay, so we've got our vitamins. When I do this sort of exercise with my students, we kind of go through each one together. And I wish we had time for that, but we don't, unfortunately. And I want to make sure to save lots of time for questions. So I'm just going to go through this. But again, feel free to chime in if you have any thoughts or questions as we're going through. So here might be what I would do. So, okay, we have a gentleman who had a acute onset. So vascular first. Okay, was there a stroke or an aneurysm or something, some sort of stroke, hemorrhagic ischemic, some sort of acute cerebrovascular event, or a heart attack would be vascular, something like that. So infectious. So this gentleman was on a safari. If he was out, he should have gotten his vaccines before he went, but was there a history of any sort of viral infections? I would want to make sure I asked about any labs, and if there was any infectious disease labs that they got, that would be a good place to go. Was there a history of falls or traumatic brain injury? I might want to ask about, did this gentleman, anything happen during that vacation? Did he have any hospitalizations during that vacation? Did he return home, as planned? That would help you rule out some of those things. But you'd be wondering about that. This presentation would not likely involve anything autoimmune. That doesn't make a whole lot of sense, unless he had like type 1 diabetes or something. So metabolic toxic is M. So this would be things like sepsis or metabolic derangements. So someone who's dehydrated or malnourished or something. But in this gentleman's case, how well is his diabetes controlled? Do we have any diabetes labs? Does he wear his CPAP when he sleeps? How well is his sleep apnea controlled? We move to I, which is idiopathic, which is we don't know. It's just sort of happened. Iatrogenic, which is things that the medical system caused. And this gentleman's only 63, but in properly older adults, iatrogenic cognitive changes are one of the most common causes. And we're talking about things like medication effects. So you would have asked for a med list if there's anything that stuck out to you based on your knowledge. And again, if this seems like a lot, this is the kind of knowledge and skill you'll have, when you get into your independent practice to be able to kind of talk fluently through these things, which is kind of cool. How is he managing his insulin if he's on diabetes? Any issues there? Doesn't sound like this is a cancer, a primary, a brain tumor or anything like that. But you probably should have asked if you had any history of surgery, and they would have told you. So rule that out. Doesn't sound like seizures. We're going to say no. There's no substance use history in this little mini vignette. Nothing about psych history that you have. At 63, it's very unlikely there's anything developmental, so we're going to rule that out. We have a family history of Alzheimer's disease. I would want to know how old was this patient's family members when they got, dementia. If they were young, then that may make him more likely to get it himself. It could be unrelated to his vacation, his diabetes, his sleep apnea, whatever. If he's not controlling his diabetes well, does he have a history of vascular dementia? I put delirium in there, which is a favorite topic of mine, but there's no evidence that there's anything acute here that's kind of caused by a medical, change. So we're ruling that out. And then finally is endocrine. So we have the diabetes, but are there does he have a history of thyroid disease, any other labs or anything like that? So again, this is a very long and kind of full differential list. You wouldn't need to do this either for practice or for the real things. I would use the acronym if you like this kind of thing, and then put a little place underneath each of them to write a few thoughts if there's something that sticks out. So you may pick 4 or 5 of these to write in. What about this? What about this? And for the others, you may just leave it blank or put not relevant. But that's kind of a little exercise of how you can use this acronym or this sort of thing in practice. Okay, so next, you're just about halftime, as we are now. You'll want to talk about or ask for any behavioral observations. Don't forget that everything from your background is data. People forget this. It's easy to do. You ask for test scores and you're so focused on that. Meanwhile, you were told all about their cognitive changes and everything in the background. That is data, so don't forget about that. You're going to sequentially request the data, asking for it domain by domain. I have a list of all the domains that you should keep in mind. A lot of these may just be no. Was there any pre-morbid testing? No. Any general cognitive or IQ testing? Well, I got a MOCA. Okay. Academic achievement for our 63-year-old? No. Motor or neurobehavioral? No. Attention, then you kind of get into the meat of it and they give you the test scores. If available, it'll be provided. You want to briefly summarize each domain and move on. Don't spend a lot of time going over individual scores unless you need to, because that takes time. And we'll talk about this more in depth here in a minute, but then you'll also see next week kind of how that might work. And then don't forget, everyone forgets, including myself, on occasion to ask about neurobehavioral or neurologic test data. More than just motor, any neurobehavioral testing that's done. Okay, so after that, you're going to move into conceptualization. And like I said, this is the bit that people really worry about because it's the most nerve-wracking, where you're having to kind of put it all together. Doing practice fact findings is a good way to inoculate yourself against some of the anxieties of the process. It's never going to fully happen. But I can tell you, when I went for boards, the fact finding was the one piece that was exactly what I expected, which was nice. It was not a surprise in the least as far as how it went. So doing lots of practice will get you prepared, and you'll have a much easier time. This is again what you do every day. So you want to summarize your findings, the test data, the behavioral obs, the background. You want to integrate your neuroanatomy. Don't forget this. It's easy to do, to jump right from the test scores to a diagnosis, but that's a way to get confused or miss things. So force yourself to ignore the etiologies or diagnoses and go from the test findings to your neuroanatomy. So in our case example, our mini vignette of our 63-year-old, we have, let's say there's evidence of some processing speed, mild executive dysfunction, that kind of thing. And this was an abrupt onset. And he's also got some, let's say, mild right arm weakness. You might summarize your findings that way. You might integrate your neuroanatomy by saying, well, there seems to be some diffuse sorts of things like processing speed and executive dysfunction, depending on the type. But there also seems to be this arm weakness, and that would speak more to a focal process. So you need to know your neuroanatomy here. You would say, there's maybe, if there's mild, light right arm weakness, there's maybe evidence of left MCA stroke. Oh, there I go. See, right to the etiology. Left posterior frontal involvement. There you go, which is perfused by the middle cerebral artery. Is there a lateralized process? If you get stuck, does it seem more anterior, more posterior? Can you at least identify what lobes might be involved? And is this consistent with the background, or are you kind of surprised? So after you've done that, then you jump to the etiology. So in our case, again, I would say, well, the fact that there seems to be both diffuse and focal findings would suggest there's kind of a multifactorial process of focal on diffuse. He may have had a stroke, let's say, a mild stroke just over a year ago. That would explain the arm weakness. It wouldn't explain necessarily the processing speed and executive dysfunction if the stroke was mild. But then maybe he's got, a white matter disease, vascular dementia sort of thing on top of it, which would explain why it's gotten worse. Because you would expect a stroke to get better over time, not worse. That would make sense. That kind of thing. If you have some differentials from before that don't make sense after you've seen the data, get rid of them. If you have more, you could say something like, well, I hadn't considered this before, but looking at the test data, it really seems like X, Y, or Z is a likely kind of thought. So I'm going to add that to my differential list. And then you want to provide an actual diagnosis. So just saying this seems like a vascular process. Well, no. Yes and no. You want to be more specific. Okay, it's a stroke with small vessel vascular disease. Okay, good. But what's the diagnosis? Well, it would be, potentially a major neurocognitive disorder due to large and small vessel cerebrovascular disease, that kind of thing. And then lastly, you're going to provide some recommendations. Think about the recommendations that you give, that you'd like to give on your reports. Again, this will be a lot more clear as you get into your practice and find a set of recommendations that you like. Think about any referrals you would make and whether the patient may need serial monitoring or reevaluation, a couple years down the line or not. Okay, so I do want to save, like I said, lots of time for questions. I purposely prepared very few slides, relatively speaking, for that reason. But as usual, it always seems to take a little bit longer to go through them. So I'm going to go quickly through this. Like I said, I will provide these slides. But I've got some tips that I came up with that hopefully will be helpful. I'm going to go through just the general ones here. So it's the thinking out loud is the piece that's tough for people. You will get better at this as you get through training and into your practice, especially if you involve or get involved with supervision yourself. People get kind of worried about ruling things out. They don't want to, foreclose on some idea, but don't be afraid to do that. You have a patient that has, a slow progressive onset of something. Well, I'm ruling out anything acute like a brain injury or stroke. That's fine. You have a 1-year-old patient. I'm ruling out a neurodegenerative condition. That's extremely unlikely with someone, who's that young, that kind of thing. So one tip I really like that I tell folks and that I use myself is after the background, when you're getting all the details that you need, everything you say or every area you discuss should be moving up a level and integrating. So what do I mean by that? So when you get your test scores, let's say you get a slate of attention scores and its digit span and a couple other things, you could just go and go, digits forward is okay. Digits backward is, yeah, it's okay. It's, maybe a little lower. Digit span sequencing is okay. And you could go through the test scores, but that's not really helpful and it uses up a lot of time. So what would be better to do would be to look at those scores and summarize it and say, attention is maybe a little lower than I'd like to see, but overall I'm not seeing any major issues. It's relatively intact. Okay, great, move on. When you get done with all the test data and get to your conceptualization, rather than going through all the domains again, you would say, the most salient areas of cognitive impairment are XYZ, and just name them. You can maybe describe if needed, but no reason to go through everything in detail again. Then when you kind of move to the next level in your conceptualization, that's when you're bringing in the neuroanatomy, you're moving it up a level again. And then after that, that's when you get to your etiology. So that kind of keeping pushing forward avoids getting stuck and spinning your wheels, which is easy to do. Remember your role as someone who's doing a differential diagnosis. Use your knowledge of syndromes to ask the questions you're going to ask during the background. So, people are always wondering, well, how do you know what follow-up questions to ask? Sometimes that becomes apparent as you move through training and you just get more familiar with different syndromes. But using your knowledge, and don't be afraid to kind of think out loud and say, well, I'm hearing this, based on what I know, I might be concerned about this. And if that were the case, I might expect this third thing to be true. Is that true? And kind of trying to get some background data that way. And that will also show them that you know your stuff. I kind of alluded to this funnel example already of narrowing things down and moving up in complexity. And then don't forget that this is something that takes time to master. I will leave the rest of them to you all, but here's some other kind of tips and tricks that I thought could be helpful. Okay, we have a brief rest stop. Unfortunately, it looks like it's in Texas. And what I want to do, because we're running a little short on time, I have a couple models of fact findings that I will email with these slides. They're models. Like I said, everyone kind of has their own way of doing things and their own comfort. I personally like to just write down my report headings and the vitamins acronym and then kind of go from there. But some people really like to use models that are a bit more involved. So I will email those out to you because I want to make sure we have time to answer questions. So I have the questions that were submitted. I am happy to address those, but I do want to first open it up and see if there's any questions that got submitted that I can address. Do we have any questions coming during the?
No questions were submitted from our end.
Oh, all right. Well, then it was either very clear or very unclear, and I'm hoping the former. Okay. So I've got the questions that, and thank you, Destiny and Dr. Morales thank you. I'm glad to appreciate that. But thank you to our ANST leadership team for emailing those questions. That was extremely helpful. So I'm going to go through a couple. Do you mind if I share? That's probably okay, right? I can share my screen with some of those questions.
Yes, go ahead.
Go through those here. Let me make it big. Okay. I think this is it here. Okay. Can you all see that Word document there? Yes. Okay.
Yes.
Cool. Wonderful. Thank you. So these were the questions that were collected and sent to me ahead of time. Again, I really appreciate that, but I want to go through a couple of these. Some of these I think we answered, but so kind of going to the general stuff first. You can, so I appreciate whoever sent in that first question. As I shared, you don't need to get the correct diagnosis to pass. It's more about just showcasing your knowledge of brain behavior relationships and being able to think through things in a logical, scientifically grounded sort of way. So obviously, if you're, way off base, that may be an issue. But if you're relatively close, or at least it's something, relatively familiar, more in the same area, that's fine. Another example I'll give. One of my fact findings, my practice ones, was a case of agenesis of the corpus callosum, which was just mean. It just was very mean. Did not get it. I landed on nonverbal learning disability versus some sort of atypical autism spectrum, which was wrong. But the neurobehavioral syndrome was very similar. So, they're like, yeah, that actually was a decent job. So again, you don't need to get it right. It's nice, but that's not necessarily the goal. It's possible to get the correct diagnosis, but not pass your fact finding, probably. So I would focus more on the process, and if you get the diagnosis right, that's awesome. We talked about frameworks and acronyms. If anyone has any other kind of follow-up questions about other frameworks or acronyms, feel free to speak up or put those in the chat, and I can talk about that a bit more, but I'm going to move on otherwise. The tips for hypothesis testing and how to integrate data wholly. We talked about that a little bit in the presentation. I think, a couple other things I would consider is don't be afraid to explain why you're asking what you're asking. So I alluded to this a minute ago. When you're going through your background, you may say, okay, well, Mr. Jones, Mr. Patient has seemed to have this acute abrupt onset, but then things got worse. That seems a little strange. Most things that are acute, like a stroke or a brain injury, would improve over time. I'm not ruling those things out, but that course is a little strange. So I'm wondering if the hospitalization was for something, or the acute event was something else that was unrelated, or possibly there's sort of a multifactorial process that's going on. So that would be a hypothesis that you're laying out there and saying out loud to kind of show how you're thinking. As far as the integrating data, I think I covered that okay. If that wasn't clear, again, feel free to speak up or put something in the chat. But using that model of scores, don't say the scores, say the domains, then talk about what functions were the most impaired, then the neuroanatomy, then the diagnosis. That is very helpful, especially when you feel like you're getting stuck. That neuroanatomy piece is what everyone forgets, and that can be helpful. And well, you're kind of thinking through things. It'll make things clearer for you. Okay, that next one I think we covered pretty well. The answer is yes, all of it, but in a graded fashion. How can you shorten the time required to actually diagnose? I think, so for that next question, we're into area 2 here. I think it's mainly a hypothesis-driven framework. You don't have time to address every possible thing, and there's going to be red herrings, right, that pop up. So my actual fact-finding case, I was told, this gentleman had this, acute onset of these symptoms, et cetera, et cetera. Medical history, okay, it's notable for a childhood head injury, okay. Ask about the head injury, loss of consciousness, sure, yep, 10 minutes, okay. How about after that? Well, was out of school for a couple days, but returned. Any issues? No. And I said, okay, ruling that out. That sounds like a concussion. Moving on. You're not going to be able to explore everything in depth, but getting enough data where you can then keep something online as a possible consideration, or say, ruling it out, moving on. That's what you want to get to. If you have low confidence, that will happen. Hopefully not when you go for the real thing, but certainly in your practice, it will happen. Like I said, this is a skill that takes time to develop. There's nothing wrong, especially when you're in training, to say, here's what I'm seeing with the data. Here's what I picked up from the background. Got this history of this patient with this kind of oddball course. There was an acute event and then it got worse. But the data aren't making sense with what I would expect, which would be this, that, or the other. Given that, kind of here are some conclusions, but I'm not, completely sure what's going on. But here's why each of these could be a possibility. That's fine. You want to be a bit more clear during the real thing, but when you're practicing, if you get stuck, talk through that. That's an asset. Talking through things is very difficult to kind of get good at, but once you do, it's easy to kind of put in more knowledge. Your supervisor will say after the practice is done, forgot to ask about, this, that would have clued you into that, which would have helped make that make sense. And you'll never get it wrong again. You definitely talk through differentials as you learn new information. I think the only sidebar to that, it can tax your working memory as you're going through your test data. The school of thought I think, is to hold off on that a little bit until you kind of get all the test data, because it's easy to get bogged down. But if there was something you were really strongly considering, this seems like a dementia, patient has a family history of Alzheimer's, it sounds like Alzheimer's, and then you get the memory scores and they're fine, you would say, this is not what I expected. These memory scores actually look pretty good. I would not expect someone with Alzheimer's disease, dementia, to have intact memory. That doesn't make a lot of sense to me. I may end up ruling that out, but I'm going to move it way down my list, and let's move on to some other data. So you could talk them through as it comes up. The shorthand tips, we talked about kind of rubrics and things. I used to like to make a little square, and it would be for left, right, anterior, posterior. And if I got a finding either through the background behavioral observations or the test data, I would write it in whatever square it went in. And if it was diffuse, I think I had a little column on the right. And then when I was done, I would look to see what square had the most stuff written in it and kind of use that as a starting point. If you're a more visual person, something like that may be helpful. And like I said, I'll send a couple models around with the slides. So we talked about the questions gathering. So the next thing about best practices for someone in a doctoral program who's on a practicum or an externship to build these skills. That's a great question. The easy answer to say, which I don't believe, is, don't worry about it for now. But I honestly think learning how to do a good fact finding just makes you a better clinician. I find myself kind of thinking through things in a systematic way, even, a number of years after getting boarded. It's just a good way to think through things. So even if you're on, an externship, if you want to start building these skills, you could start using your vitamins acronym. If you're working with your supervisor and you're saying, hey, let me take a crack at differential diagnosis, write some things out. Maybe sit with your supervisor and talk through what you're seeing or not seeing to kind of get at answering things in an analytical way. That will certainly build the skills, help you talk out loud, and also get you used to thinking kind of broadly for your differentials. And that should make you a better clinician, which is sort of the point. It's nice to pass boards, but it's even better to be better able to serve your patients. So that would be a recommendation I would have. I don't know if there are actually, I'm wrong. Yes, there are plenty of practice resources. So there's a group called BRAIN, Be Ready for ABAP in Neuropsychology. The acronym is a bit tortured, but it's a wonderful organization. I think you have to be graduated from postdoc to join, and it's free. But they have a listserv. There are study groups that you can participate in, and that's how most people prepare. Is they get a study group, and you can do that for the written exam too. But at least for the orals, joining a study group and doing mock fact findings. Reach out to old mentors from your practica, folks you're working with now, or supervisors or colleagues at the time when you're in independent practice, and have them go through it with you. Reach out to someone random. So I've done a number that of people I don't know, that a colleague would say, hey, my my old practicum buddy, his student is going through boards and needs someone they don't know to kind of run them through. Do you mind doing that? And I'll always say yes. It's a good thing to do. So you can do that, but those resources will help you prepare, and those are all free. Okay, I feel like giving a fact finding in an internship interview is mean. I know we're running out of time. I'm sorry, but people do it. In brief, I got one, and I wasn't prepared for it. I didn't do very well. I would just, if you're given something, what they're really wanting to do is probably see if you can get like a high base rate syndrome. So I did this once to someone. I remember giving them like a CVLT printout and being like, look at this memory pattern. What do you see? And it was seeing that it's like a non-amnestic memory pattern. But if you are given something like this during an internship or postdoc interview, I would try to keep it very brief and not try to go all vitamins on them, because it's gonna be overwhelming. And just say, okay, let's run through a clinical vignette. Here are some initial questions I'd have about this patient. After they answer those, say, okay, well, here are some possible differentials. Here's the testing battery I would normally give to answer those. And if they give you more data, you could then pull that together in brief. But I would try to keep it pretty surface level. And other advice, that's a whole nother talk. I would love to, but yeah, I think being humble, honest, but confident of your own accomplishments, and ask good questions. That's always something that I look for when I'm doing interviews. Folks who know the program, and it's very obvious when people don't know much about your program and they kind of aren't very interested and don't know what to ask. So ask some good questions about the program that you're interviewing at. I have AI. That's crazy. Okay, well, I would be very skeptical of using AI to do practice fact findings for a couple of reasons. AI hallucinates, so most of you probably know what that is, but it likes to make things up. These large language models are it's probability math is what it is. So when asked a question, the highest probability response is the one that's given. Doing a clinical fact finding is a super specialized skill. That was very alliterative. Such that a large language model is probably not going to be very good at it. It's kind of a niche thing. But even if it will, the hallucinations mean it makes things up. There's been, so many examples of funny things. I asked actually AI late September. I said, "Is our schools in session today?" Because my traffic on the way to work was really light, and it said, "Yes, today is Labor Day, and schools are out for the day." It wasn't Labor Day. It was like the end of the month, but that's how it answers questions. So it's liable to kind of lead you in a way that sounds credible, but is leading you not a place that's going to make you a better clinician. So I would avoid that. Oh, I'm only 2 minutes over. That's actually pretty good for me, unfortunately. Any other questions or comments or anything from the folks that are on the call? Okay, I'll take. Oh, yes, that's a great question. So next week, we're going to do basically a live practice fact finding You don't need to do anything other than observe. I'm probably going to be the guinea pig in the hot seat because, finding someone who volunteers to be evaluated is difficult, and I don't mind. So I'm going to have a friend evaluate me on a fact finding, and you're going to get to watch kind of one live. I'm going to go kind of quick because I want to save a little bit of time at the end to kind of discuss things. But it's going to be like a real fact finding example, and hopefully I do okay. Karina, that is a wonderful question, and I apologize for not covering that. No, you get asked when you go to your fact finding, the actual real fact finding, if you want an adult or a peds case. They have one of each. So there is essentially no chance you're going to accidentally get a case that you have your choice. So shouldn't be a concern. That's a good question. Kayla, that's also a really good question. I would love to tell you kind of a basic, intern applicant appropriate level of knowledge. There are folks in our field who love to ask difficult questions and torture people during interviews and be a little like that. So I can't, I'd love to tell you that the expectation is going to be appropriate, but yeah, no, I know. I have someone I mentored went to an interview. I won't tell you where with whom, obviously. And the first question he asked her was, "So, Gerstmann syndrome, the 4 tenets, go." And he apparently used that as a way to gauge people's anxiety. She knew it because we had a case recently, and that was not expected, which I was like, good job. But right. So people do that kind of thing. That's those stories are fewer and far between. Most of the time, it's perfectly lovely. But if you're asked during an interview, I would expect a relatively cursory level because you just don't have also the time to kind of get into it. What they're probably looking for, like I said, is something really specific. Like they're going to say, you are referred a patient who has, a strong family history of Parkinson's disease. This patient is 42 and recently developed a tremor. What other details about the background would you like to know? And you might think through and be like, okay, 42 seems awfully young. And you may ask about how is his sleep? What age were people in the family when they got Parkinson's disease? Any drug use? And that's when you may get told, yes, he has a history of heroin use, which he bought, in some back alley. And you may say, could it be a drug-induced tremor or an essential tremor? That would probably be more advanced than what they're looking for, but it should be that kind of contained. It shouldn't be anything more than that, and maybe even simpler. So I wouldn't worry too much. It does happen, but usually they're looking for like one thing specifically. Yeah, you're very welcome. Good questions. I know we're over time. If anyone has any additional questions, feel free to put them in the chat right now. I don't mind sticking around for an extra couple minutes. And if not, obviously that's okay too. But
I think we might be all squared away.
No problem.
Thank you so much Thank you so much, guys, for joining us this Friday. And hopefully we'll see most of y'all next Friday. And thank you so much, Dr. Kamper, for presenting this talk.
You're welcome. I will send out the slides and those 2 rubrics I mentioned, and I appreciate everyone coming by. So see you next time. Thanks.
Thank you.
See ya.